So with that, I am going to introduce our next presenter. And Dr. Saad was born and raised in Dearborn, Michigan, and has a passion for his local community and is committed to providing exceptional health care to his patients. At his full-time service, Dr. Saad offers primary care services and specializes in the treatment and the management of addiction, and we are so excited about that. He is a dual board-certified physician specializing in internal medicine and addiction medicine. And as you heard earlier, we have very few of those. We need more physicians. So Dr. Saad, that's a call to action I can give you to make sure we get more physicians that are going to also be dual certified. He is privileged to work with the Detroit Wayne Mental Health Authority and its providers, peer recovery coaches provided by Hagera Health, FAN, and GrowthWorks, as well as partnering with the Greater Detroit Area Health Council, the Drug Enforcement Administration, and the Michigan Department of Licensing and Regulatory Affairs, among many other organizations, to improve provider education and patient care. So bring him on, Dr. Saad.
Thank you, Dr. Dudley, for that introduction. Hello, attendees. Thank you all for your valuable time today. And thank you to the people at GDAC and Detroit Wayne for providing this forum to share ideas and awareness for all of us. My goal today for this talk is just to share with you how our office adapted and how we use medication-assisted treatment for substance use disorder in the office setting, and the changing that's happened due to COVID, and how we've responded, how we changed our practice. So my name is Dr. Abdulhassan Saad, and we will start this presentation. So the discussions that I'd like to go over, the topics. So the parallel paths. What we do here in the office and how medication-assisted treatment care has changed. So we started at a baseline of face-to-face encounters with our patients pre-COVID. We had no telemedicine visits taking place in our office at pre-COVID. All our visits were done frequently. Patients came in, seeing me face-to-face, seeing our peer recovery face-to-face, our peer recovery coach, and medication-assisted treatment was provided that way. COVID came, there was new emergency orders, which sort of necessitated a rush to virtual healthcare. And we in my office needed to adapt to be able to provide the medication-assisted treatment that was required, but to do so in a post-COVID or in a COVID environment. So necessary services evolved as a part of our virtual care. And I'm going to go over some of the adjustments we made along the way. Now, some revelations, 8 months into this, we've seen is if you're able to balance both in-person visits and the virtual healthcare, it's allowing us to see our patients more often, coach them up more often, and keep them in recovery longer. So what is a typical in-person encounter that we do here in our office? So gone through a well-evolved process. So we initially start with a face-to-face collection of detailed history. We go over their family history, their social history, where they live, their medical history, their drug use history, if they've been at any rehabs, paperwork they've brought with them. That's done in a face-to-face initial visit. And then we do a complete physical, we do complete vitals, and we get a complete blood drawn along with urine testing. That's all done at the initial visit, face-to-face. And then we go over, current situations they're in, health situations they're in. Most of these patients that I'm seeing in the office for MAT, medication-assisted treatment, also have diabetes or heart disease, and they've completely ignored their medical health because they're suffering from their addiction. So we try to address those issues as well. And then we conduct our ESPER, which is our screening brief intervention, and then we try to set up a treatment plan for them. In that same initial visit, pre-COVID, we had our peer recovery coach in our office. Once I was done with them, the physical was done, they were referred back to the peer recovery coach, who then did a similar face-to-face collection of history. There was no physical done, but they set up a more recovery plan or outlook as to how they were going to work together. Now, during the initial visit, there was an assessment, there was care plan, we had some dialogue with patient. We tried to initiate everything that day on site. We prescribed or we administered medication-assisted treatment-related medications that were required, whether it was an oral medication or an extended release injection that we needed to use, like Vivitrol. And then we also set up their referrals. So they needed a behavioral health coach. Our on-site health coach set that up. Sometimes they had their own health coach. Our recovery coach would reach out to their recovery coach. Majority of these patients were seeing a psychiatrist or needed to see a psychiatrist for other mental health problems. Our recovery coach helped assist with those appointments, facilitate them. And then we had the patient return for follow-up and to reassess where they were. So that was our typical, rundown of an in-person encounter during the pre-COVID days. So then COVID came and we had this telemedicine explosion. So we needed to adopt a telemedicine approach to continue to deliver the care we were providing pre-COVID, and also to reduce the risk to everyone involved dealing with COVID. So we agreed as a team, me, my director, some of the other practitioners in our office, some of the mental health people we worked with, that virtual care was going to be the safest approach, but we also understood that we did need to see the patients at times. So we needed to come up with a way where we could do the virtual care and balance it with seeing them in person to continue monitoring. So we immediately initiated telemed outreach once the state shutdown occurred. So we got, all of our patients that were on schedule on a day-to-day basis. Before that day came in, we called them. We explained to them what's going down. We explained that the state was currently in a shutdown, and this should not interrupt their recovery. This should not interrupt their care. We were going to stay open. We were going to help manage their visits. And we were going to transition to have their visits done virtually while we were trying to fight the COVID infection as well here in the office. So the basics of the office visits were managed while providing the necessary substance use disorder care. Now, the virtual office visits, we realized, were eliminating one barrier to these patients' recovery, which was transportation. It was also eliminating the barrier of patients having to take off work that day to come in here. So we've seen more patients actually not missing appointments, not skipping appointments, and we were also starting to see through these last 8 months that people were actually doing better and in recovery more often. Based on their urine drug screen results, I was able to monitor that. Without telemedicine to treat substance use disorder, I fear that we could have had many more relapses than we did during the COVID era. So other services that evolved over the last 8 months, substance use patients at home needed the care too. So our team partners, along with our staff, began to evolve. We had new technology. There was a lot of different platforms that you could use to start virtual healthcare. We chose one that we felt was the easiest to our patients and the easiest to our staff. And we started the frequent virtual visits with our patients. So from their home, we reached out to them in the morning, we gave them a time, we gave them a link, and we started a virtual health visit and started having them check in more often, reaching out to them, making sure that they're taking their medication, that they're seeing our recovery coach, that they're seeing their psychiatrist, that they weren't running short on medications, whether it was for their diabetes or for their substance use disorder. We made sure that their health was being addressed while the state was in a shutdown. Now, the in-person visits, we did not eliminate those during these 8 months. They were still necessary. One thing they were necessary for was to get the urine drug sampling from the patients, to make sure the patient was compliant with the medications, that there was no diversion taking place. So we continued to have them coming in here to address those situations. Also, we had to continue in-person visits for Vivitrol, which was an injection. A lot of the patients that were on it were really worried they were going to miss their dose, and that would cause them to go back into a relapse state. So we continue to stay open for those. Also, the Sublocade injections that we do offer here now, we were continuing the injections during this process as well. But their follow-up visits were done virtually. So they would get their injection, and then their following visit before their next injection, our recovery coach or I called and we did a virtual visit with the patient. Now, other larger institutions, government programs also evolved their thinking and supported these changes immediately, which allowed it easier for our office to make the transition, whether it was Medicare, it was the state, it was the CDC. We were able to work with these institutions to make sure we're all following guidelines and our patients were receiving the best care possible. Now, the adjustments we made, it was a speedy change. You could say it was almost like an overnight change. We launched the telemed outreach with the governor's stay-at-home order. We realized that still transitioning for best experience and robust delivery of compliant telemedicine services following eventual end of emergency orders would be most beneficial to our patients. We had to discontinue the on-site recovery coach visits. And the reason for that was to reduce the risk of COVID infection. But we launched virtual peer recovery coaching with our peer recovery coach and our patients. So they still did their visits, it just wasn't on site. And our visit protocol has become more refined. Most monthly in-person visits are followed up with a bi-weekly virtual visit, consisting of screening, brief intervention. If they need any type of treatment or referrals, we did it during our virtual visits. And we promoted the behavioral health component as well through the virtual component. So the next visit, when they would come in, allowed us to oversee their compliance to treatment. So we would get their urine drug screen done when they actually came into the office as well. Now, what has the last 8 months revealed to us? So one thing it's revealed what's working and what hasn't worked. So we believe here in our practice, we kind of figured out a little bit of a medium, a happy medium for our supportive televisits in between our mandatory office visits. And this has allowed us to improve retention numbers. It's allowed us to improve patients in recovery longer. Our patients tell us they feel better. They're able to talk to their doctor. They're able to talk to their provider while they don't have to take off work. They don't have to find a ride to get here. They don't have to find a babysitter to get here. This allows them to feel motivated to do their visit, to not skip a visit, and continue to stay in recovery longer. Regardless of your medication-assisted delivery system, whether it's an extended release Vivitrol, Sublocade, or an oral medication, the screening, brief intervention, referral, and treatment, and repetitive contact is helping patients stay connected and recovery longer. And this allows patients to do better. So just, based off these last 8 months, what I've seen is the more I talk to my patients, the more I coach them, whether they're on site or it's done virtually, it allows patients to continue to stay the program, stay doing better. If they're getting a craving, they're able to talk about it. They don't have to wait a longer period of time before they can bring it up and have a bigger chance of relapse. They can bring it up virtually and we're able to get the treatment that they need. Now, the biggest increase in help that these virtual visits have allowed is that initial risk of relapse period that can occur at the beginning of treatment. So a return to on-site introduction of patients to peer recovery coaches is what's anticipated, hopefully once we can get this virus down and we have treatment options for the virus. And I think that'll really give us optimal results there. So that's kind of a rundown of the parallel of pathways of how we were treating patients for medication-assisted treatment in our office pre-COVID, and how we adapted post-COVID or during the COVID era, and we were able to institute virtual healthcare along with our on-site visits and continue to provide successful treatment. So I did leave about 10 minutes for discussion or questions in my slides. For anybody that has any questions, we can go over.
Thank you so much. Thank you for being the boots on the ground, because we so much need this. We have several questions that we want to throw at you. You ready? All right. One question was, they were curious about the billing for the peer recovery coaches, both for in-person, and are the peer recovery coaches also doing services virtually?
So that's a great question. So here in our office, we don't actually bill for the peer recovery coaching services. They're actually provided through Hygira Health, GrowthWorks. We allow some office space for their recovery coaches to be in my office. So I don't do any billing for the recovery coaching services. Now, if Hygira or GrowthWorks are billing, I'm not entirely sure how they are compensated for their time. What I'm able to do is link up with successful programs that have recovery coaches and have them on site. That's what I've been doing, but I have not been billing for their services. And we did transition to virtual healthcare for the recovery coaches. So now they're no longer on site. Our patients leave and they do their virtual recovery visit with our recovery coaches.
That's great, because at least that's another way, when you were talking about repetitive contact, that's going to be available. The next question was, how often would a face-to-face encounter need to take place during COVID for the urine testing?
So, there's no specific timeline with urine testing. There's some recommendations from, ASAM, American Society of Addiction Medicine. There's some from SAMHSA. There's some from the CDC. I kind of follow a weekly urine sample pre-COVID for the first 3 or 4 visits, make sure their urines are clean after 3 or 4 visits, and then go to a monthly schedule and then space it out based on how the patient's urines are looking. If somebody who's consistently turning out clean, I'll start doing it once a month, once every other month. Post-COVID, I'd have to space them out a little bit more since they're not coming in as often to the office. So I've been doing it monthly now. Once a month, they'll come in and drop me a urine sample on site so we can monitor them and prevent diversion.
Prior to COVID, we know that even in Detroit or in some of the minority communities, the opioid epidemic was not going down. It was not going down at a rate that we saw across the state. But part of the challenge also is that what we talked about in the beginning is that many of our physicians are not certified in addiction. And to be able to use the medically authorized treatments that are available, how would you, and how did you, one, come to say, hey, this is something that was important to your practice, and then how would you encourage other physicians to also get engaged?
Yeah, so I think it has to start with the medical schools, the residencies, the PA schools. We need to build a more education platform as people are becoming doctors or graduating from residency as to what addiction medicine is, how we have to provide it, how big of a problem it is. Because once people go into private practice or, they graduate, if they're not taught it during their education and building their foundation, it's a little bit harder to change the way they learn later on. It can be done, but I would really emphasize on the new providers that are graduating, the residency programs, the newer doctors that are getting out there, that we need to start setting up, our DEA waiver as part of standard treatment or standard education for our psychiatry residency programs, our internal medicine, our family residencies. Those are the important ones that need to be waivered once they graduate residency, because at least they got waivered, was part of their education, and then once they're on their own, they can utilize their education versus somebody who's been in practice for 15, 20 years,
Right.
trying to take them back to do the studying to provide addiction services. I would really want to focus on the newer graduates and make it part of our basic education and curriculum, the addiction medicine field.
Do you think that that's something that can happen? Are you affiliated with some of the universities and the residency programs to encourage that?
Yeah, absolutely. I think it can happen. I am affiliated with some PA programs. So Wayne State University PA students round with me, Central Michigan round with me, along with Western Michigan students. I'm an adjunct professor at some of those universities. We take, their PA students are required, those programs, to do 8 hours of MAT training before they graduate, which is very important. And then they're doing their rotation. Some of the students in my clinic, they're able to see what MAT treatment is. So I am working with some of the local universities, and I do think it can be done. And I really think if we're going to make a difference, it's going to be done at the universities. We all know it's a problem. Overdose death right now is the #1 killer for anybody under the age of 45 in the United States, based on the recent numbers. So we know we have a huge problem. And with the newer graduates, we know we can make a difference. We could get more people graduating waiver, more people graduating familiar with addiction medicine and how to treat different medicines. And even if they don't want to treat it, at least they can recognize it and they know what to do. They know where to refer.
Right. One other question we have here is that what recommendations would you have for other clinicians who are wanting to get more involved in the community?
Reach out to their local health authority. So when I first opened in 2016, I reached out to the Detroit Wayne Health Authority. I went downtown. We met with Darlene, who really helped me out, connected me to Higuera. There's a lot of local health authorities in the area you're in. At least in Wayne County, I'm familiar with in Macomb County. And those are people I reached out to, and that's what allowed me to get closer to the community, start to be more of a member, a vocal person, and almost like a referral source for patients that needed help. So they start to send patients to me because they know I'm invested in this and I want to make a difference in the community.
Great. We're on a virtual platform. You talked about telemedicine. One question was, have you found any issues with patients not having reliable technology, internet services for telehealth visits? And how have you negotiated this?
Oh, that's a great question and a great point. So we initially started with one type of virtual health provider in our office, and it was creating big issues. A lot of patients don't have laptops or computers or up-to-date technology. Most people do have a cell phone, a smartphone though. And the virtual health provider I was using was giving me issues with some of the smartphones. We actually switched the virtual platform that we used for that reason. And it's a very simple platform I'm using. But if we do attempt to do a virtual visit, the patient isn't able to do, some patients still won't be able to do the video visit. We would switch it to a telephone visit until they can get in person and, make sure we're talking to our patient and go that route if we have to, because we don't want to just cut a person off during a visit because of a technology issue.
Another question was, how do you know when the best approach for a client is MAT? And what constitutes that decision? Is it solely based on opiates and mental health or just opiates?
So as a primary care provider first, we are doing ESPR on our patients yearly, right? You're going through their social history. You're trying to see if they have an issue with alcohol. You're trying to see if they have any issue with smoking. And if you have an open relationship with a patient, you'll even go over drug use. Is there any drugs that you're abusing? Also, their MAPS record. If you're reviewing their MAPS, you can kind of see, is my patient using, medications, going to different doctors? Is there something going on? That comes from the provider doing the screening portion, trying to get more information from the patient. A lot of times, the patient will come in to the office and they don't want to discuss these issues, these substances that they're having issues with. Sometimes we have to pull it out of them. And when we do, medication-assisted treatment, there's so many different avenues to use different medications for a drug use disorder. So the first thing is to identify what drug is the patient having issue with. Is it alcohol? Is it an opioid? Is it cocaine, or whatever it may be? And then give the options, put them on the table and go over what options you have available with the patient and set up a route of action with the patient and go from there. So medication-assisted treatment has definitely been very crucial in providing the care to these patients. And I kind of just go over with the patient and decide when it's a good time to actually use medication for their treatment.
Are you having any challenges with having those services reimbursed?
Excuse me, I didn't.
I said, are you having any challenges with having those services reimbursed through insurance?
So with Medicaid, with the state, they pay for medication-assisted treatment. I think about 2 years ago, we used to have to fill out authorization forms to get medications approved, which would take time before we could get the patient started on treatment, which increased the chance of the patient relapsing and not coming back. All those authorization forms, were removed by the state and allowed me to start treatment quicker. So I do think it's gotten much better over the last few years. Overall, I don't have any issues, being paid for my services. No, I think we're doing a good job.
Are private insurers also on board with reimbursing for MAT?
So yeah, some of the private insurances might give you issues with what you're, when you're billing and what you're not billing. So what you want to do is make sure you get the right codes, reach out to providers. So for example, we had a meeting with Blue Cross to see what services we can bill for, what we could provide. Reach out to the providers. And now I've become almost like a referral center for some of the commercial insurances. They have case managers who will send patients to us for treatment for opioid addiction. They'll actually identify some of their own patients who are having issues with drugs and then say, hey, why don't you go see this provider at this location and get the help that you do need.
We want to thank you so much for being the boots on the ground, for being the voice, and also encouraging our residents, our new doctors, to get involved in a issue that is impacting across the nation, across demographics. It has no allegiance to who, what, when, or where. So thank you. Thank you for the time that you spent with us. Other questions that we may have, we'll send them to you, and I'm sure Nikki will make sure that our audience get those answers. So thank you for your time and your commitment to making a difference.
Thank you so much. And I do want to also give a shout out to Detroit Wayne for also providing peer recovery coaches for our patients and giving them, numbers to help our patients as well. Once again, thank you for the time and thank you for this platform.
Great. This brings us to a break in all of the action, a break in all of the information, and it'll give you time to absorb some of the things that you've heard, to take note of some of the things that you have been called to action to do, and things that you can work on together to collaborate to help address this issue of opioids and the opioid epidemic in the midst of this pandemic. So, we have a short break. We're going to be away from you for how long we're going to be away? 15 minutes. So you can please go to our virtual booths, go and interact with some of our sponsors. And so that's more information that you can have. And I think there was one question on how can we connect to the community. This is certainly one way to do it. So visit our virtual booths and we will see you back here in about 10 minutes. Thank you.